We are going to have the oration ceremony, and Mr. Arul Immanuel is going to be the orator, and I request Dr. Mr. Paula Rajesh, the Vice President from Royal College of Edinburgh, to read the citation about the orator. Before I'll try to connect to HC Doctor. He's really excited. He and his family would be also keen to watch from home. I'm sure they're already watching. And over to you, Mr. Paula from Scotland.
Thank you very much. It is a great honor to be in the UK at the present time to deliver the oration of the HD Doctor Award to my colleague, Mr. Arul Emanuel. Mr. President, distinguished guests on the dais, ladies and gentlemen, it's a great honor to present Mr. Arul Emanuel from Newcastle as the first HD Doctor orator of the Indian Association of Gastrointestinal Endosurgeons during this first Indo-UK SURGICON 2020. This is an IAGES and the Royal College of Surgeons of Edinburgh's first collaborative conference. Arul currently works as a consultant in general and upper gastrointestinal surgery at the Northern Esophagogastric Unit in Newcastle upon Tyne at the Royal Victoria Infirmary. He graduated from Madurai Medical College and pursued his postgraduate degree in MS in surgery from my alma mater at the Madras Medical College before proceeding to the United Kingdom for his further training in surgery. He did his surgical rotations, obtained his fellowship in general surgery in 2007 from the College of Surgeons of Edinburgh, and he pursued a period of research at Newcastle under the tutelage of Professor Mike Griffin. He was conferred the Doctorate of Medicine for his work in identifying the prevalence and susceptibility of metachronous and synchronous cancers of the esophagus and head and neck in December 2006. He then pursued a period of fellowship at the Flinders University Hospital in Adelaide, in Australia, and returned back to set up an advanced laparoscopic and robotic surgical management center in Newcastle along with Mike Griffin. His interest was in benign esophagogastric conditions and minimally invasive robotic surgical approach to cancer of the esophagus and stomach. He has extensive surgical experience in that he's performed more than 300 esophagogastric resections, and he continues to perform from the largest number of resections from the largest center in the north of England. He has established an internationally acclaimed enhanced ERAS program for patients undergoing resections in the unit. He has presented and published extensively, including his research work in the field of esophagogastric surgery in numerous scientific forums and many internationally reviewed, peer-reviewed journals. He has, to his credit, several publications and abstracts. He is deeply passionate about patient care. He takes great pride in being a team player and an excellent communicator with patients and their relatives. He is an enthusiastic teacher and always enjoys teaching and supervising the development of junior medical staff and his colleagues in the unit. He is a fellow of the Edinburgh College and a member of the Upper Gastrointestinal Surgeons of Great Britain and Ireland, and a member of the International Society of Diseases of the Esophagus. President, ladies and gentlemen, it is a great honor and privilege to present before you Mr. Arul Immanuel for delivering Dr. H.G. Doctor Oration on esophagogastric surgery, past, present, and future during this Indo-UK SURGICON conference on this day, 16th October 2020. Thank you.
Thank you, Mr. Pala Rajesh. Arul Emanuel, before you go in for your oration, just I take you briefly to Dr. H.G. Doctor. It's an emotional moment for them. Let me see whether I can connect with them just for a few minutes.
Dear AGES, I thank you very much for having the 2020 oration in my name. It is indeed an honor and a privilege for me that the association has bestowed this oration on me. I'm very pleased to know that the association that we doctors co-founded is growing from strength to strength. Thank you and all the best for IAGES 2020.
Give a big hand. I think it is a very emotional moment. Thank you for the affection the family showed, the granddaughter showed. I think it was really nice. I think Arul Immanuel, you are gifted to give this speech. I think this first of its kind under the name of Dr. H.G. Doctor. And over to you, Arul. You can share the screen now.
Thank you very much. Thank you, Rajesh, for the very kind words. And good evening to all of you. And I bring greetings from Newcastle upon Tyne in United Kingdom. I would like to thank all the organizers of the IAGES for giving me this wonderful opportunity. And it does make me emotional that, that I'm presenting the first Dr. Oration. I read a lot about him last night, and it is indeed my privilege and pleasure to give the oration in your name. And clearly you've been one of the pioneers and a visionary of not only Indian, but Asian and global surgery. Thank you very much. As Rajesh had introduced me, I am Arul Emanuel. I'm a consultant esophagogastric surgeon, and my practice is at the Northern Esophagogastric Cancer Unit in Newcastle upon Tyne, United Kingdom, which is the largest unit of its kind in not only in the UK but in Europe. And the reason I say that is we see about nearly 700, 800 cases every year. I do have a disclaimer before I go into my talk, is that my talk is purely on the art of esophageal surgery, as it would be impossible to cover all aspects of esophageal cancer, or indeed I wouldn't be doing justice to it in the time I've been given. So in the UK, we see more than 9,000 cases of esophageal cancer diagnosed every year. Majority of them are adenocarcinoma of the esophagus, which is slightly unlike the rest of Scotland, one of the highest incidences of this subtype of cancer in the world. The overall mortality still remains very high and is one of the highest in the country in comparison to other cancers. This remains the case worldwide, irrespective of the histological subtype. So what I'm going to do is in the next 10 to 15 minutes, is to walk you through the journey, how esophageal surgery has evolved and the role it has played in improving lives of patients with this unfortunate disease, and to look forward with a lot of hope of progressively improving outcomes with the art of surgery. In the early 1900s, the diagnosis of esophageal cancer was primarily a death sentence. Not only was it a death sentence, but also a miserable and a painful one. It was really in the 1980s when surgery was more widely practiced as a treatment for esophageal cancer, more with hope rather than intent, but the intent was of better palliation. The outcomes were still very dismal. In the late 1980s, the mortality following esophageal surgery was around 75%. In real life, only 1 in 3 patients who had this operation actually left the hospital after the operation. Move over to the 1990s. As the survival figures started to improve and the belief that surgery does offer a chance of cure for this dreadful disease, the focus now turned to how best can this surgery be done. The debate still continues, though there is some consensus that in comparison, transthoracic esophageal resection has lower anastomotic leak rate, and in locally advanced cases, there's a higher rate of R0 resection, a higher lymph node yield, with the hope of a prolonged survival with transthoracic resections. As surgery became firmly established as a cornerstone for esophageal cancer survival, the debate then included and focused on how radical surgery should be. Again, this depends on which side of the fence one sits in. You will find evidence and literature to support this. However, what is clear is that radical surgery does adhere to oncological principles we have all been brought up in. It does offer a better staging. It does offer better local regional control, and hopefully should translate into better survival. Looking into the UK survival statistics, the Cancer Research UK regularly put out the statistics. The 1-year survival for esophageal cancer is between 70 to 80%. And this drops down to about 50 to 60%, and then to 40 to 30% in 3 years. And if you look at the 5-year survival, it's still very dismal, around 20 to 30%. The associations of surgeon of the Association of Upper GI Gastrointestinal Surgeons in the UK do collect data on the number of resections performed in the country, along with their morbidity, mortality, and the outcomes. Now, if you look at this chart, this is where Newcastle stands. And this was the last data set from 2019. This indicates that the Northern Esophagogastric Cancer Unit performs the most number of operations in the country and has done so since the last 25 years. Okay, we do perform the most number of operations. How does this translate into outcomes? If you look at the chart and if you look at the graph, we have seen a progressive increase in the 5-year survival since 1990s. And in 2017, when we analyzed our last 5-year cohort, the overall 5-year survival was 47%. How is this compared to the national statistics? If you look at the statistics on the right, it's currently around 50% when we analyzed our next 5-year cohort. So to the Northern Esophagogastric Cancer Unit, we cure 1 in 2 patients who undergo surgery. And when you compare this against the national outcomes, the stark difference is quite obvious. We are in the process of publishing our 25-year outcome and survival data. As you can clearly see, that there is now a consistent survival of over 50% 5-year survival. And this includes every patient that walks through the doors of our hospital with esophageal cancer. We now know that surgery, if done well, and of course with the advent of new chemoradiotherapy regimes and better quality of care, results in good survival. The focus now turns to how do we reduce the morbidity of the significantly morbid operation. It is very fitting that Sir Alfred Kosheri is in this amongst the dignitaries, because he performed the first minimally invasive esophagectomy in the world. By this time, around the 1990s, minimally invasive techniques had exploded within the various fields of surgery. There was, however, a delayed and slightly muted acceptance of this within the OG fraternity, and for the right reasons. The initial embracement of this technique did result in increase in morbidity rather than decrease, because corners were cut, resulting in some serious complications. However, the general concepts of minimally invasive surgery, which includes less blood loss, less complications, less pain, faster recovery, is still very applicable to minimally invasive esophagectomy as well. In 2003, Jim Lukatich from Pittsburgh in the United States first published his paper on about 222 patients. This became a pioneering concept, the publication of attaining sentinel status. Since then, there's been many studies publishing results of various forms and techniques of minimally invasive esophagectomies. However, there remains ongoing debate whether which is superior, or which is the best technique. The first randomized controlled trial in looking into open versus minimally invasive surgery was the TIME trial by Miguel Questa group in Amsterdam in the Netherlands. They published saying that respiratory complications were much less, hospital stay was much shorter, the quality of life was better after minimally invasive surgery. No, there was no difference in oncological survival. Another important study by the late Christophe Mariette from Lille in France compared open surgery to a hybrid approach. Again, the criticism of the study was a very high rate of complications in the open group, and it did include a heterogeneous group of surgeons. However, further oncological and quality of life data is still to come, and I believe this is going to be published in the next couple of weeks. Having said that, this is the only RCT study to have shown a difference favoring laparoscopic mobilization. Turning attention to global outcomes. The global collaborative data platform was set by a dear friend Don Lowe from Seattle. The concept was actually birthed at an ESD meeting in Newcastle. Now, most of the major units in the world input their data into this platform, and I'm sure many of you do so as well. At this juncture, I would like to thank Don for providing me with the slides. An initial analysis of the data set a few years ago revealed globally around 50% of the cases are performed in a minimally invasive manner. Again, this was very similar to a review which took part in Netherlands in 2017, where again, 50% of the cases were done in a minimally invasive way. The dataset seems to suggest that the common approach seems to be a transthoracic one, and when performed minimally invasive, there is a mix of hybrid techniques and minimally invasive techniques. Again, there was no difference in the lymph node harvest when the procedure was performed either minimally invasive or open. There was no difference in the length of stay, or even in the event of complications, there was no difference between the two techniques. Again, there was no difference in the length of stay whether the operation was performed transhiatally or through a transthoracic approach. This was the same when the operation was performed in a minimally invasive manner as well. What's happening in the UK? The last set of statistics suggests around 41% of the operations of esophagectomies are performed in some form of minimally invasive manner. This, I'm sure, has gone up, but I'm sure it's not more than 50% at the moment. So this was a randomized controlled study by the Jane Blaisby group from Bristol in the UK, which I believe we're waiting for the outcomes to come. And they looked into randomizing patients into an open group versus a hybrid group versus a totally minimally invasive group. What's happening in Newcastle? We adopted a minimally invasive technique back in 2015. And over the next few years, we modified the technique. So I'm trying to play the video. And we published our initial outcomes, which was at least comparable to the open technique, if not better. Our survival data has just been accepted for publication, which suggests that the minimally invasive cohort of patients do have a survival advantage in the long run. The way we designed our program was one surgeon did the first 50 cases to get over the learning curve. And now 3 of us in the unit performed this operation. And clearly, the learning curve was much shorter for the other 2. Despite the never-ending debate of whether minimally invasive surgery is better than open surgery, what is clearly evident is it is safe to say that minimally invasive esophagectomy is definitely non-inferior in terms of oncological outcomes, complications, mortality, and length of stay. What about the quality of life for these patients who undergo this morbid procedure? Again, there's a plethora of literature out there. A well-studied recent publication from the Lagergren group in Sweden from Karolinska University, which was published last month, suggests there's no difference in the quality of life between open and minimally invasive esophagectomy. This is both inclusive of short and long-term outcomes. In fact, a follow-up analysis of the time trial from Miguel Cuesta's group suggests that minimally invasive esophagectomies performed outside a trial setting actually resulted in increased complications and reoperation rate. So where's things gone wrong for minimally invasive esophagectomy? Why has the minimally invasive approach not become the standard approach, unlike many other surgical specialties? And why cannot this procedure be replicated consistently? Those who do this operation, for starters, do understand esophageal surgery is an extremely complex operation with serious outcomes, which result as a result of complications associated with it and the profound morbidity associated with it. In this setting, minimally invasive surgery should be offering a better solution to this problem with this better vision and access, but it's still very much limited by a 2-dimensional vision, varied and distorted eye-hand coordination, loss of dexterity, and variable quality of assistance. So where do we go from here as an OG community? I mean, clearly standardization in surgery has been proven to improve efficiency, clinical outcomes, and patient safety. However, this has been near impossible in esophagogastric surgery, at least till now. Standardization in surgery is not a new concept. Robert Dickinson, an eminent obstetrician from Brooklyn, New York, published this article in 1914. He said, "A man with a shovel and an apprentice bricklayer have got more standardized approach rather than a trained surgeon." And he concluded his article by saying that there is good evidence in 1914 to say that surgical advances will be irregular and erratic unless standardized. Medical field indeed has seen a lot of standardization, including protocols for treating patients, classification of diseases, complications, and so on and so forth. However, surgical technique seems to vary not only amongst nations, but within individual units, and indeed amongst individuals as well. All our randomized controlled trials, studies, collaborative efforts, unfortunately have not resulted in improved surgical outcomes, despite great advances in surgical techniques. Certainly, minimal invasive surgery was a great step to bridge some of the gap which exists between units and nations. However, the world statistics, as we looked before, tells us only 50% of this operation is being performed in a minimally invasive manner. Certainly, laparoscopic and thoracic surgery and thoracoscopic surgery has been a great leap for patients, but not enough to make a clean difference. And in many ways, it's been a step back for surgeons. How do we tackle this? Could technological evolution be the answer to this? Robotic surgery might be an answer to this. Sorry. There's been one trial which has been published from the Richard van Hilliger's group in Netherlands. It's called the robot trial, where they compare the open versus robotic esophagectomy. And according to the trial, there was a reduction in pulmonary, cardiac, and overall complications. There's been a reduction in blood loss, improvement in objective post-op pain, better quality of life in 6 weeks, and also comparable oncological outcomes. Since then, there has been an ever-increasing publication of case series suggesting non-inferiority of robotic esophageal surgery. What is becoming increasingly evident is that through robotic surgery, the steps of surgery can be replicated quite easily, taught better due to some incredible vision and freedom of movement. And this may be the step in the right direction towards standardization. The case you're watching now is a D2 lymphadenectomy whilst performing a gastric mobilization for esophageal cancer. So we're taking the common hepatic node off the artery, and the dissection now proceeds on to the gastrohepatic ligament with excision of the gastrohepatic ligament node, going up to the porta, then clearing the portal vein. You'll see the portal vein in a minute. Then exposing the left gastric vein and artery. The left gastric vein and artery are then clipped and then cut. And then the dissection is carried on to the splenic vessels, taking all the lymph glands on the splenic vein and the artery. This certainly could be standardized and could be repeated, which we have found the case in our unit. And again, when you go to the thoracic part, again, this could be a very standardized approach to the mobilization of the esophagus. For lack of time, I'm not going to go through the whole video. I'll just come down to the anastomosis. And again, The esophageal anastomosis following 2 stages of ejectomy is the bane of most of the esophageal surgeons. A purse string is employed. And the mini thoracotomy is done, through which the specimen is taken out. A circular staple is inserted. You can use ICG to assess the right place. The anastomosis is carried out. Then end to side anastomosis. And then an omental wrap is performed to strengthen the anastomosis. As surgeons, we've all been in a situation we have to think and act outside the box. And I'm sure surgical experience in this setting with a multidisciplinary team approach will continue to defy and aid standard practice. So this is a patient who had previous colonic surgery and had extensive esophagogastric cancer, and he was reconstructed with the colon, and the middle colic was supercharged to the internal mammary artery. This is how it looked prior to supercharging, and then this is after supercharging. You've all listened to endoscopic surgery from the professor of the Royal College of Surgeons yesterday, so I'm not going to go into the details of endoscopic surgery, but this forms a major part of our routine work in Newcastle. We do about 100 and 135 endoscopic resections of early esophageal and gastric cancer, and this is now almost a standard treatment for all our T1A disease and also for staging purposes. This has been published extensively, and this is now a very standardized technique in the unit. And we have shown that, patients who undergo this treatment do have excellent survival for early cancer. So to come to conclude, current practice of minimal invasive operation and robotic surgery will expand. Further advances in surgical systems will aid in improved techniques. Preoperative simulation and artificial intelligence will facilitate the surgeon to do better surgery in the future. And I'm sure in time, individualized surgery will come with sentinel node mapping and sentinel node navigation. So President, organizer of the meeting, dignitaries, ladies and gentlemen, I would like to finish by saying that it is important to adhere to the time and tested principle of surgery, which included optimal staging, endeavor to reduce local regional recurrence, improve overall survival, and improve quality of life. Operative approaches may have an impact on outcomes. However, other interventions like enhanced recovery and better chemoradiotherapy techniques might have a greater impact. However, quality of surgery must be identical with any approach we employ. Thank you very much for this opportunity.
Thank you. Thank you, Mr. Arul Immanuel. That was a great talk with a clarity and conviction. We have with us the President-elect, Dr. Sunil Papat, to say a few words and a formal vote of thanks. Over to you, Sunil.
Thank you very much, Mr. Arul Emanuel. It was a very concise and very thorough lecture on the esophageal cancer and what is happening now and what is the future. I'm very impressed with the training part of thing which you narrated and you discussed, and certainly with the collaboration between IAGES and Royal College of Surgeons of Edinburgh, the Indian surgeons and UK surgeons, I think we will be delighted to send our fellows for training in future to your center and to other centers in UK for the advanced training in laparoscopic surgery, and similarly vice versa. At this juncture, I would like to pay my tribute to Professor H.G. Doctor Sir, in whose memory this oration has been started. This is the first oration, and I'm very delighted to see Dr. H.G. Doctor at his home, and he's one of the founder member of IAGES, and he has nurtured this association over last 25 years. I'm thankful to my co-chairman, Dr. Ramesh Agarwala, and Mr. Rajesh Pala, Vice President of Royal College of Surgeons of Edinburgh, for being here with me in chairing this session. And I thank President Raman Goyal and Honorary Secretary Ishwamurthy for giving this opportunity to be along with these giants of laparoscopic surgery today evening. Thank you all very much.
Thank you, Sunil. Thank you, Mr. Pala Rajesh, and thank you, Ramesh Agarwala, for having shared this session.
Good evening, friends. It has been a wonderful journey for all of us during this pandemic year. And IAGES partnered with the IAGES Edinburgh to give these important sessions on INDO-UK SURGICON, especially the forehead sessions. In fact, forehead sessions have been a runaway success, where one could see a galaxy of international experts and a galaxy of speakers talking on various important subjects. The last week has been an exciting journey of having a relook of what has been happening in these important sessions. And Docplexus have been kind enough in hosting us yet again on behalf of the IAGES to take back to the golden memories of listening to the global experts. So let us have a brief relook of what has been happening in the forehead sessions. The expert sessions were shared by Professor Inian Samarasam from Christian Medical College, Vellore, and Dr. Kaushik from Siliguri. To start with, the president of the IAGES for 2021 started the sessions with the most important and ever sought after laparoscopic fundoplication. In fact, Dr. Sunil has 2.5 decades of experience in handling laparoscopic fundoplication. He touched upon the most pertinent issues on fundoplication and what are the questions we are staring at when we have come through a long journey of standardization and safe outcome of fundoplication. The most pertinent challenges are we reach the right technique? And Sunil very effectively concluded telling individualized approach is the right approach with due investigations and evaluation before considering an operation for fundoplication in the patient. Then we move on to the GERD operations. None other than Professor Pandit Lal. He went on to challenge the standards of GERD. Do we divide the short gastrics or do we not divide the short gastrics? First of all, whether it is needed at all, and what are the pros and cons of dividing the short gastrics. And it's been a lot of learning for us when we could see the benefits on either side, and the so-called formula-based approach, all the short gastrics have to go, is no more true. Then we had the fortune of watching the fine hands of Dr. Sailesh Puntambekar from Pune. He went on to demonstrate a wonderful skill set being expositioned on the minimal invasive D2 esophagogastrectomy. Somehow or other, esophagogastrectomy has been always a challenging procedure. A distal stomach, body stomach is the most common general surgical procedure anyone would face. Here, Dr. Sailesh has very categorically mentioned what is the extent of surgery, what is the radial clearance required, and what are the nodal dissections, what are the safety of the nodal dissections. Thank you, Dr. Sailesh, sir, for making us to learn the right way to do this procedure. Then our ever youthful and most energetic laparoscopic surgeon, Dr. Sarfraz Ali Beg, he went on to reminisce the challenges he has been facing in the benign esophageal surgery. And in fact, he gave a treatise of various surgeries which has been happening over the past 2 decades on benign esophageal surgery, how to face it and how to come out if there is a complication. So that is about the expert talk. Now we move on to the next batch of the sessions. The free papers, I would be doing injustice if I call it as a free paper session. Most of them were very senior faculty, showing that the best of the upcoming minimal invasive surgery techniques in the foregut surgery. We had the fortune of having Dr. Pramod Shinde, Dr. Om Tantia sharing this session. None other than Dr. Subramanieshwar Rao highlighted the importance of esophageal condivascularity by the ICG imaging. And in fact, it was a lot of learning because the most dreaded complications of foregut surgery is the anastomotic leak. And that happens when you are not sure about the vascularity, and what may look like okay, ICG highlights the vascularity may be little insufficient. So that's where you have the opportunity to do the adequate amount of trimming so that the anastomosis is secure. Thank you, Dr. Subramanieshwar Rao, for sharing your expertise on that. Then we move on to Dr. Sudarshan from Chennai, who has brought in a wonderful case of gastric volvulus. He touched upon the various components of the early evaluation, early stabilization. What is the right way to reduce the volvulus? And he went on to tell how to repair the volvulus and how to tighten the hiatus and what are the steps to be taken for preventing a long-term recurrence. Thank you, Dr. Sudarshan, for highlighting that. Then we move on to something, I would say, an unusual complications of mesh in giant hiatus. It was a series by Dr. Shobhit Singha, where he went on to show the retraction of mesh, the erosion of mesh, the fistulization, the most tough complications of mesh. Thank you, Dr. Shobhit. I'm sure all the audience would have enjoyed and learned from your thing. Then something translational. We should appreciate the efforts taken by Dr. Krishnakant, where he went on to do the study, post-operative tissue study following gastrectomy, how and what is the prevalence status of Helicobacter. And then he also highlighted the importance of Helicobacter eradication in these patients. Then subsequently, we had the very eminent panelist and the most important moderator. It is indeed a global outlook of what are the training and research issues by the global leaders of foregut surgery. One could see the galaxy of speakers: Professor Simon Law from Hong Kong, Professor Simon Dexter, Professor C.S. Ramesh from the Tata Memorial, Mark Smithers, and Homer Weiss from USA. In fact, it was a half an hour of power-packed deliberations on various issues, and then subsequently they moved on for another 20 minutes to talk about various components of research issues, how foregut surgery is going to go. Thank you, Professor Simon, for coordinating such a wonderful international panel discussion. Then the master videos, the best of the class master videos, chaired by Professor Vijay Abraham from Australia and Mohammed Ibrahim from Madurai, both of them leading foregut surgeons and surgical oncologists by themselves, where one could see the mastercraft of Professor Rajinder Prasad's LS cardiomyotomy. In fact, he made arithmetic approach towards the LS cardiomyotomy, 1, 2, 3, 4, 5, and 6. So that makes the job very clear and lucid and makes the job of the learner and people who want to perfect the technique of myotomy should witness this video again and again for making a very categorical approach. Then we could see the mastery of Professor Sanjeev Haribhakti, where he went on to discuss about the cystogastrostomies and cystogenostomies, the use of foregut for drainage of the pancreas. What an art it was. He highlighted the importance of edge biopsies, highlighted the importance of secure anastomosis, highlighted the challenges of doing an anastomosis with stomach and small bowel to the pancreas, especially the inflammatory cysts and thick wall cysts. Thank you, Dr. Sanjeev, for highlighting the various aspects of pancreatic anastomosis. Then we had the masterclassman, Professor Jimmy So from National University of Singapore, where he demonstrated the gold standard of gastrectomy, the minimally invasive D2 gastrectomy. Starting from the port placement ergonomics, he went on to say medial to lateral, lateral to medial, what are the pros and cons, and how to safely remove all the nodes, and what is the clear margins, how to achieve that, and how to give a oncologically safe operation in these patients. Then we had the fortune of listening to handling various types of foregut gastrointestinal stromal tumors by none other than Professor Ajay Upadhyay from the USA. What a master surgeon he is. He went on to show us the difficulty of fundal gist, body gist, as well as the tail gist. So it is a must watch for all of you. I would say you can revisit these videos as many number of times, as these are not common operations, but then it has its own exclusive nuances which have to be taken into consideration when you're going to do this operation. Thank you, Dr. Upadhyay, for helping us to learn this handling of GASD. Thank you for identifying and telling us the cases which will benefit from endoscopic assistance. I would say in a hybrid operation helps in these patients, and the usage of appropriate staplers from the appropriate port ergonomics makes the surgery a feather. Thank you, Professor Upadhyay. Then we had the fortune of having a masterly chairing of this session, the debate. The debate has been always the highlight of the meeting, and we had Professor Avinash Shupe from Mumbai, and we had Professor Abdul Majid Chowdhury from Pakistan chairing this session. And add to the crown and the jewel on the crown, we had the master batsman, Professor Ajay Kriplani and Professor Murthy from UK debating on this tight issue. Again, rocks were trembling, mountains were crumbling, but still both of them stick on to their guns. And it was very clear the road has to be traveled in parallel, and there is no crossing of roads each other. There were clear incidences, clear indications for not to use mesh, and clear indications to use mesh. So this science will be challenged for decades to come. But I'm sure they both of them have given us a very big clarity on handling this part of operation. And I'm sure at least we have learned where not to use mesh and where to use mesh. So it's been a wonderful journey all through, and I am happy to bring out the outlook of the foregut sessions. And I'm sure IAGES this year also are going to work hard to give yet more exciting academics. And we look forward to having you amidst us in the near future for the IAGES 2021, the International Annual Congress to happen in Coimbatore. We welcome you one and all. Thank you. Thank you for staying with us all through. Thank you, IAGES, and thank you, Docplexus, for making this possible. Goodbye.